we're going to switch gears and talk about dermatologic issues in kids with Down syndrome. This talk was created together with Dr. Renee Howard, one of our professors of pediatric dermatology at UCSF. We thought about doing this in tandem, switching mics, and then we figured it might be best if one of us presented the information, but she will be presenting next about dermatologic issues in all individuals with disabilities, and we'll be answering questions together, aka she'll answer all the questions about dermatology. Still nothing to disclose. We're going to talk about common dermatologic issues in individuals with Down syndrome, talk about some treatment modalities, and then identify which things to refer and which things to manage in your own offices if you're a doctor. So let's start by talking about cutaneous features in children with Down syndrome. A variety of dermatologic issues are more common in Down syndrome. The single transverse palmar crease, please do not call it a simian crease, that's insulting, is the most common cutaneous finding. It's unilateral, but it's also very common in the general population. In general, transient cutaneous manifestations are more likely to be seen early on in life, while their more chronic skin conditions tend to emerge later on in life. There are several predisposing factors to having skin stuff. Number one, I think hypotonia. When you're a baby, you're more likely to stay in one position. So the neck, the armpits, the inguinal folds are going to be chronically exposed to moisture, which can lead to rashes. Lying on your back all the time can lead to rashes, bald spots, pressure sores in rare occasions. The low oromotor tone often leads to drooling. Poor coordination with feeding leads to milk facials and food facials, which are not great for the skin. And then the delayed achievement of continence means that someone's going to be in a diaper for a longer period of time, also predisposing to rashes. Premature aging also predisposes one to skin differences. Premature onset of age-dependent changes like hair graying and thinning and wrinkling. And it's thought to be related to lower basal level of DNA repair enzymes, especially the decreased ability to repair UV-induced DNA damage, as well as possibly overproduction of oxygen-free radical. The superoxide dismutase gene is on chromosome 21, and oxidative stress has been linked to T-cell-mediated skin diseases, from psoriasis to seborrheic dermatitis to contact derm and atopic derm. Immune dysfunction also plays a role. Individuals with Down syndrome all have a sort of a relative immune deficiency, no unifying diagnosis, but definitely abnormal antibody-mediated and cell-mediated immunity. In vitro, we've seen reduced killing of Candida albicans and Staph aureus. And then unclear whether this translates to clinical significance, because studies that have looked at zinc replacement have not are old. They're all from the 80s and 90s and have not shown a huge difference, but increased prevalence of zinc deficiency may have something to do with increased dermatologic issues as well. Increased risk of autoimmunity, which is well described in individuals with Down syndrome, obviously has an effect on the skin. Some autoimmune diseases have dermatologic manifestations. This is dermatitis herpetiformis associated with celiac, but also thyroid disease, diabetes, autoimmune hepatitis can have skin presentations. And then some autoimmune diseases directly affect the skin, from vitiligo to alopecia to psoriasis. So, from here on out, I'm going to take you through a whirlwind tour of skin conditions. I have 30 minutes to go over 30 slides, so I will have to go quickly. Everything is in your handouts, and I made the slides a bit busy so you could refer to them in your handout if you come up with any of these issues. Starting with vascular lesions, pretty much all babies will have some degree of cutis marmorata or livedo reticularis, which are very, very similar conditions. When a dermatologist thinks of livedo reticularis, they think autoimmune, rheumatologic conditions, but when it comes to kids with Down syndrome, it actually doesn't seem to be associated with vasculitides. They're more prominently seen in cold temperatures. So whenever my nurses undress the babies to weigh them, you can see the cutis marmorata. You can see some cutis and livido in the pictures above. You don't have to refer cutis. It will go away on its own. It will probably take longer to go away than most other babies without Down syndrome, but it's not scary or dangerous. Vascular malformation. I couldn't find anything in the literature that showed a clear increased risk of vascular malformations in individuals with Down syndrome, but what we do know is that our kids with Down syndrome are at increased risk of atresias throughout the GI tract, including anal atresia. And anal atresia is associated at times with vascular malformations as part of bigger syndromes such as pelvis and sacral syndromes. I love dermatology because all their syndromes make complete sense and have cute names. So pelvis stands for perianal hemangioma, external genital malformations, lipomeningomyelocele, vesicorenal abnormalities, and imperfect anus or a skin tag. Sacral is spinal dystrophism, anogenital cutaneous, renal, and urologic anomalies, and angiomas in the lumbosacral localization. So this is an example of one patient with this rash that would be paler and then become red and then become purplish and then disappear. And this child has anal atresia and also has a tethered cord and really fits the picture for one of these syndromes. And vesicourethral reflux really fits the picture for the syndrome. Transient myeloproliferative disorder is seen with increased incidence in individuals with Down syndrome. It's a transient proliferation, aberrant proliferation of some cell lines. And some kids need treatment. For some kids, it resolves on its own. And then the more serious version, congenital leukemia. Both of these conditions can be associated with dermatologic manifestations. Congenital leukemia is associated with leukemia cutis, which are these blue, firm, infiltrated papules and nodules. And then for leukemoid reactions and transient myeloproliferative disorder, kids can have vesiculopustular eruptions, such as the one seen in this textbook or peer-reviewed article picture. There should be a differential because it could be, of course, herpes, staph, congenital candidiasis. However, a CBC might give you a clue into what's going on, because if you see a whole lot of white cells, then it's probably transient myeloproliferative disorder or congenital leukemia. And it resolves with treatment. The treatment is not geared at the rash. The treatment is geared at the blood cell dyscrasia. Atopic dermatitis is common. According to the literature, about as common as it is in the general population, which is common. Xerosis cutis, so dry skin, is so common. Everybody gets it, or almost everybody has dry skin. I can never generalize. And it tends to get worse with time and with age. And certainly having dry skin and a non-intact skin barrier can predispose you to have irritant contact derm and allergic and contact dermatitis. So gentle skincare needs to be emphasized from the very beginning. I won't use names or brands. I just say if you can smell the soap, it's not good for you. If you can smell the lotion, it's not good for you. And, you know, we talked about sensory issues, but if you get used to this baby being lubed up all day long from when they're babies, then it's just going to be a part of their routine, as opposed to if you try to start moisturizing a teenager with sensory issues. Eczema is also common, where I see it a lot is the cheeks. So malar erythema is very commonly seen in kids with Down syndrome, especially in the winter. Many of you are quite familiar with treating eczema. So gentle skincare, topical steroids when indicated, and managing the staph colonization that can worsen eczema. Most eczema doesn't need to be referred. If you get stuck and you cannot get good results and you know that the family is actually doing what they're supposed to, then you should refer. But the cases that are referred for atopic derm are few for Down syndrome from me. Cutaneous infections are common, ranging from folliculitis to furuncles, to abscesses, to secondary impetigo in someone with eczema. A study, there's the same few studies are referenced throughout this talk because there aren't that many people who are looking at dermatologic issues in individuals with Down syndrome. I want to note that some of these studies were done in institutionalized patients, and so we have to keep that in mind when thinking about our sample size and the factors of living in an institution that could affect the skin. But Sheepis et al. Found folliculitis to be the most common dermatologic condition in their study population. It was a mix of bacterial folliculitis, which is very common in the gluteal and perianal region, as well as pityrosporum folliculitis, which is often seen in adults with Down syndrome in the chest and infrascapular lesion. How do we treat it? If it's bacterial, we often use eradication measures, so your diluted bleach baths, topical antiseptics like Hibiclens wipes, and then topical clindamycin gel is often very effective at controlling the bacterial folliculitis. For pityrosporum, topical ketoconazole, your Selsun Blue basically, but you don't want to put shampoo necessarily on the skin, so you can also get 2% ketoconazole lotion, but you may need oral treatment, and a single dose of flucon is often enough to eradicate pityrosporum. So you don't really have to refer folliculitis unless it's refractory complicated. Subderm is super common, and it has like a bimodal age distribution. Babies, but all babies have some, or most babies have some subderm cradle cap on the scalp and on the T-line, or the T region. And then later on in older childhood, often presenting as itchy dandruff. Strong association with pityrosporum folliculitis, and for babies, as Dr. Howard says, who is it bothering, the parent or the child, right? So you can do mineral oil in a comb, but you may use hydrocortisone. For older children, ketoconazole 2% shampoo or Selsun Blue can control subderm very well. You don't have to refer it unless it seems really hard to treat because the differential of subderm in the scalp is scalp psoriasis. And so if you don't get good control with these measures, then it might be psoriasis and it probably needs a dermatologist input. Keratodermatoses are very common as well. Keratosis pilaris has a well-known association with Down syndrome. 15% of individuals with Down syndrome were found to have KP in one study. And what it is the hair follicles get plugged up with dead skin cells, which creates this rough texture. It often happens here and on the thighs, and it can be itchy and it can be dry, and the treatment is trying to use non-soap cleansers to allow the skin to retain its moisture, but exfoliating the dead skin cells can be helpful, and then using moisturizing creams, especially moisturizing creams containing urea or salicylic acid, can be very helpful in controlling KP. Palmoplantar hyperkeratosis is also very common. High prevalences in some studies. I have to be honest, I don't see as much of it as what's quoted in the studies, but it's well-defined hyperkeratotic plaques that are distributed at pressure points of the palms and soles. And the treatment is emollients and keratolytic agents. You can use topical steroids and topical retinoids and topical vitamin D ointments such as calcipotriene. These are things that don't need to be referred unless they're complicated, refractory. And a lot of families come in saying, I need a dermatologist referral. And I feel very empowered to say, okay, how about I try to treat the rash, since there's a long wait to see the dermatologist because there's few excellent people like Dr. Howard. And then if we get stuck, then no problem. And I feels real good to solve people's issues without having to send them to yet another specialist. Periorificial dermatitis, I see it a lot. There are periorificial papules and pustules, and they can start as isolated papules and pustules and can become more confluent. And they're on the spectrum of rosacea. So if you're familiar with rosacea, you know that it can flare and then it can go away, and it might flare with the time of day, with temperature. Hopefully my kids are not drinking alcohol, but it can wax and wane. The predisposing factor is steroids around the area, and how many of our kids are on intranasal steroids or inhaled corticosteroids if they have asthma. So think of that mask with spacer with mask as an offender. And then, to be frank, sometimes you don't know what it is. You think it might be eczema, so you're like, let's put some steroid on this, and it gets really upset. The treatment, topical antibiotic gels like metronidazole gel or topical Clinda gel can be effective. Sometimes it flares the rash before it makes it go away, which is hard for the family to see. And you can use systemic treatments like doxycycline at acne doses for a couple of weeks or azithromycin at pneumonia dosing, and it will melt the rash away. If it fails the first light treatments, you should refer for further guidance. Certainly some of these bother the parent more than the kid, but I definitely see a lot of kids scratching and really bothered by the rash, so that's something that I like to treat, especially if I see excoriation marks. This I find very interesting. It's thought that there's higher concentration of calcium in the sweat channels of people with Down syndrome, which might lead to sweat duct calcification, which leads to these MILA-like calcinosis cutis, which are these small, discrete white papules that look like milia but are more firm and look chalky, like there's calcium in there. And usually they're asymptomatic. They're not bothering anyone. Someone might think they're a wart and get real freaked out by it, but otherwise they're not that bothersome. And no treatment is necessary unless they're painful, and if they're painful, they can be curated. And they shouldn't be confused with milia, like those seen in under the eye in the picture below. But either way, you're not going to do much about it other than reassure. Syringomas are similar to milia, but they're small, flesh-colored, yellow-brown dermal papules, and in our individuals with Down syndrome are very often seen in the eyelid, and that's actually much more common to be seen under the eyelids than in the general population. There's a female predominance as reported in this very recent study from 1964. And there's an association with the milia-like calcinosis cutis, so wondering if it's some sort of similar pathogenesis to it. They're not easy to treat, and they don't bother anybody other than the child if they don't like how they look, or the parent if they don't like how they look. So I would say refer only if the kid is bothered by it, because if the kid is bothered by it, then we should treat it, right? If someone is having self-esteem issues and image issues related to these, then, just like we would for anybody else, we should refer. But if nobody cares, then leave them be, because treatment is electrocoagulation, cryotherapy, and neither of those feel great. Vitiligo consists of depigmented, generally well-demarcated areas, not hypopigmented, right? So it's not just lighter than the skin, it's like white. The estimated prevalence is 2% as opposed to 1% of the general population. There is an association with hypothyroidism, so I do check TSH and free T4 and even the antibodies in kids who come in with vitiligo, as well as alopecia areata. They will light up brightly under woods light, as shown in this picture. And in terms of treatment, it's difficult to treat. You can start with topical steroids like 0.1% triamcinolone, maybe even Lidex, and then you might need to add topical tacrolimus, and then light therapy is very effective, but talk to Dr. Howard for 2 minutes to get to hear what light therapy access is like in our area. Non-existent. Sorry I spoiled it. This is something that should be referred because we're talking about big gun steroids, big gun immunosuppressants like tacrolimus. The focus of treatment is generally more on the face than on the body, and I think that part of the focus of treatment is also acceptance and positive body image type messaging, because it is hard to treat and it's unlikely that we'll be able to make all these spots go away. So feeling comfortable with them is important. And then some people use makeup to cover them up if they're not comfortable with them. There's famous models with vitiligo. If you want to look at awesome pictures, look up Positive Exposure by Rick Guidotti, a famous fashion photographer who decided to start photographing individuals with all different genetic conditions in a way that's respectful, as opposed to the textbook pictures with the eyes blocked and the genitals visible. Alopecia areata is also more prevalent in individuals with Down syndrome than in the general population. There's a possible female predominant. Again, there's an association between genes that live on the 21st chromosome and alopecia, specifically MXA, the product of MX1 gene, which is an interferon-inducible protein that is strongly expressed in the lesional anagen hair bulbs from patients in alopecia areata. It is associated with vitiligo, thyroiditis, hypothyroidism, trachonicia. So again, if I see it, I check thyroid levels and thyroid antibodies. It tends to be more severe in individuals with Down syndrome and harder to treat. Topical steroids are the first line, but you should refer. I don't think you should hold off on starting topical steroids as you refer because I told you to start, because Dr. Howard told you to start. But do refer because, again, this is hard to treat. The next three things I'm going to talk about are related to weight, which takes me on a tangent. Please do not use the Down syndrome growth curves to evaluate for obesity in individuals with Down syndrome. Growth curves are normative curves, like, take the bell curve and turn it into curves. So if there's a condition that's prevalent in 50% of the population, then what will look 50th percentile and average on that growth curve is actually going to be obesity, and you're going to miss obesity. So please, please, please use the CDC growth curves when evaluating weight and BMI for individuals with Down syndrome. Newer studies from Children's Hospital of Philadelphia suggest that the 85th percentile for BMI in individuals with Down syndrome actually represents obesity based on different fat distributions. Acanthosis nigricans starts as flat hyperpigmentation and then becomes velvety. It's often seen in the back of the neck, also in the armpits. Many patients think that the kid is dirty, and really it's a skin change. It's associated with insulin resistance, and we have to think about that because the incidence of diabetes mellitus, both type 1 and type 2, is higher in our patient population of individuals with Down syndrome. There's a really high prevalence of being overweight and obesity, as I just said. And then newer studies are showing that actually an extra copy of the DSCR14 gene from the 21st chromosome actually leads to dysregulated hepatic glucose homeostasis and pyruvate intolerance, which is likely what explains the higher incidence of non-alcoholic fatty liver disease in our individuals with Down syndrome. So I am strict about sugar at our parties. There's no juice, there's no soda, there's just water. And I talk to everybody about limiting sugar intake and not rewarding with food because of these issues. You don't have to refer to dermatology for acanthosis, but maybe consider referring to nutrition, consider referring to endocrinology. I follow a skinny mini who's had acanthosis for a couple of years, and I'm watching her A1C rise, and I think she's gonna reveal herself as a type 1 diabetic soon. Hydradenitis is another condition that's associated, that's made worse by being overweight or obese. They're inflammatory pustules, nodules, and abscesses that are often seen in the armpits, the groin, and sometimes the inframammary region. And they are not infections per se. They're not the boil that you lance and then you solve the infection. They are related to an inflammatory reaction to bacterial skin colonization, so we cannot take the blame completely away from staff, but unfortunately you won't be able to treat it forever just by lancing them or giving antibiotics. And if not treated promptly, then they can lead to fistulous tracts and become much, much harder to treat. The incidence in individuals with Down syndrome is higher than in the general population, and we do have a USCSF study going on right now on hydradenitis. The age of onset is younger. Hydradenitis has a clear female predominance in the general population. I have not seen studies specific to Down syndrome, but again, because there's a genetic underpinning, I suspect that female predominance might not be quite as marked. Treatment. Part of it is weight loss, because again, this is exacerbated by being overweight or obese. Topical cleansers, diluted bleach baths, the skin colonization measures are important. You can start with topical Clinda for mild disease and see if that works. Systemic treatment with like taking doxycycline or clindamycin all the time might be needed to control both these antibiotics both control the bacteria, but also have on their own anti-inflammatory properties that help control hydradenitis. If that fails, you might need to use a combination of rifampin and clindamycin. Oh my goodness. And then really, really good results with Humira. And at a recent talk that Dr. Nicole Kittler, one of the new UCSF dermatologists, gave at our Grand Rounds in Oakland, she actually recommended referring early for dermatology, because I think sometimes we beat around the bush and let this get out of control when this could have been ameliorated a lot earlier with immunologic treatment. I have a patient with hydradenitis, and we tried the wipes, wouldn't tolerate them, tried topical, wouldn't tolerate them, tried antibiotics, wouldn't tolerate them. And I was like, Mom, I think that we might need to go to injections. And I was floored. She was like, please give me injections. I don't want to fight with him all the time. Just once a week is so much better. So also forget your biases, because parents might feel very differently from you about escalating treatment. Psoriasis also has an association with weight. Psoriasis is a chronic inflammatory skin condition characterized by clearly defined red, scaly plaques with the Auspitz sign, where like it bleeds if you scratch it, right? Okay. And you should look for it in the scalp as well. Actually, that's where I see it the most. I don't have as many patients who have scalp psoriasis elsewhere. The majority of my patients have it on their scalp. And if it's just on the scalp, keeping the hair short and using things like tar gel and ketoconazole shampoo can control it often. Sometimes we do have to use topical steroid lotions as well on the scalp, but keeping the hair short, especially for the males, and those other two measures are quite effective. If it's on the skin, then the treatment is more intensive. It involves high potency topical steroids, vitamin D ointments. Dr. Howard will talk more about that. And the differential includes Sebderm, crusted scabies, other things. But this is something you should refer. Doesn't mean you can't start treatment, especially if you have a wonderful dermatologist like Dr. Howard, who will answer you at all times of the day and night. But this is something that should be followed by a dermatologist. A word on oral manifestations. Macroglossia. Sometimes kids have a big tongue, and sometimes the tongue just looks big because the oral cavity is small. The tongue can be fissured, it can be geographic, and this is super common, and it's not scary, and I just reassure. Lip fissures and a lot of angular cheilitis. I think that has something to do with that impaired killing, fungal killing on the skin. It's quite common, and the treatment is some topical Lotrimin at first, and then you can add a little bit of hydrocortisone after a couple of weeks. You don't want to put steroids right away on something that's thought to be fungal, otherwise fungus is going to throw a party. You don't have to refer unless the cheilitis develops some sort of granuloma because of picking or touching or excessive inflammation. A word about institutionalization in dermatology. When you read these articles about dermatology and Down syndrome, it talks about high rates of onychomycosis and scabies. And the question is, well, is it truly because of an inherent thing with Down syndrome, or is it because you studied patients in an institutionalized setting where things like scabies mite can spread like wildfire? What we do know about scabies is that individuals with Down syndrome are more likely to have a crusted scabies type of presentation, and one of the thoughts is that maybe they feel the itching a little bit less due to differences in sensory perception and processing, and that could lead to a more wide spreading of the scabies mite. I did it. So thank you for your attention, and we'll answer questions together after Dr. Howard's talk.